The meeting is being recording. Okay. हेलो ज्वाइन करो आप करो हम्म
A very warm welcome to all of you for today's webinar on an important topic, pain in chronic pancreatitis. We hope this session will foster insight discussion. It's my honor to introduce a well-known esteemed doctor, Director of Pancreatology, Asian Institute of Gastroenterology, Dr. Rupjyoti Talukdar, and esteemed panelist who brings wealth of knowledge and expertise to this discussion. Dr. Sanjay Banerjee, Dr. Arunima Goswami, Dr. Adarsh Choudhary, and Dr. Shiran Shetty. Rupjyoti sir, over to you now. Thank you.
Okay, so let me share the slides. Okay, just a moment. So, okay, it's visible, right? The slides are visible.
Right.
Okay, a very good afternoon. Okay, very good evening. Let me correct myself. So I think this is the third panel discussion series by Zuventus. The earlier two were on acute pancreatitis, early management, and type 3C diabetes and PEI. And both actually went very well. We had over 400, 350, 400 audience with very good interaction. And I hope today also we'll be able to interact not only among the panelists, but also with the audience and try to address some of the queries. So today's theme would be pain in chronic pancreatitis. And we named it as navigating the maze of broken tubes and tangled wires. Because as we all know, people who are interested in pancreatology, chronic pancreatitis, they know the concept of wiring and plumbing problems. So it's like how to go through and try to solve some of the complex issues. Most of them probably we do not know thoroughly as yet. So for that, we have a distinguished panel of experts, which includes pancreatologists, gastroenterologists, endoscopists, surgeons, and physicians. And it's always important to have a physician in this kind of a group because most of these patients would first attend the physician or the ER where the physicians would see. And how they are handled by these physicians largely will lead to what will happen eventually. So first, let me introduce today's panelist, Dr. Adarsh Choudhary. You have already heard the names, and Dr. Adarsh Choudhary actually needs no introduction. He's the chairperson, No, sir, you really don't need introduction, but still as a formality, I'm doing it. He's the chairman of GI surgery, bariatric surgery and GI oncology of Medanta. And he's actually credited to have begun the first GI surgery department in the country. And he is one of the thinking surgeons whom I respect a lot for his thoughtfulness, for the scientific way of doing his work, and for his wittiness. He has this great quality of this humor, which he keeps everything alive.
So today I also like you.
Thank you, sir. And then we have another very astute clinician, a senior physician, Dr. Arunima Goswami from Guwahati. She is currently, I think, the chairperson of the API chapter of Assam. We have been associated for a long time after coming back from, I knew her since my MBBS days, but we had contact when I worked for a short duration in Nemcare Hospital after coming back from US. And we had great interactions. And I mean, there are lots of things to learn from her, how to deal with the patients and I mean, the demeanor that she has and the way she carries herself, like it itself is a great thing to see. And
thank you so much.
and thirdly, Dr. Shiran, my friend, and he is currently the head of the department of gastroenterology and hepatology in Kasturba Medical College, the deputy superintendent. He has held a fellowship of advanced endoscopy and very well published, very good endoscopist, and of course, great gastroenterologist. And last
Thank
but
you, sir.
my close
Thank you,
friend,
sir.
yeah, most welcome, Dr. Sanjay Banerjee. Again, he is a trained gastroenterologist, but he has a deep passion for the pancreas, have been doing lots of work in pancreas. He was the associate professor of gastroenterology SSKM, but now he is the head of the department of hepatology, gastroenterology, and endoscopy at ILS Hospital, Dum Dum, and also the director of Kolkata Gastro Care. He had actually founded the Kolkata Pancreas Club, and last 2 to 3 years, they have done amazing programs, and I was fortunate enough to be a part of that. So thank you, Dr. Banerjee, for that. So without much ado, let's go into the discussion proper. So we'll all know about what chronic pancreatitis is. And if we can arbitrarily divide it into few stages, which are not watertight. There are lots of overlap, like the early stage, in which there may be changes only in the parenchyma. So, so is my mouse pointer working? Can you see my mouse pointer?
Yes,
Yeah,
it's working.
okay.
Working, sir.
Yeah, so this is on the extreme left, a normal pancreas. On EUS, this is a normal parenchyma, but in the early stages, there will be only some changes in the parenchyma. But as the disease progresses, the pathological hallmark could be progressive fibrosis. With time, fibrosis increases. And then also the other morphologic hallmark sets in, like calcification, stones, strictures, ductal dilatation. And eventually, in the long run, we will see gross pancreatic atrophy, and then there will be endocrine dysfunction and exocrine dysfunction. Now, the usual tendency to think is that there are lots of stones in the duct is dilated, and that leads us to the knee-jerk reaction to clear the duct, remove the stone, do a surgery. But it is very, very important to remember that the primary disease is not in the duct. The primary disease is in the parenchyma of the pancreas, where it originates in the acinar cell, in the ductal cell. And what we see in the duct, the changes in the duct in the form of stones and strictures, they are complications or result of the disease. So it's important to design the treatment accordingly. Right, so let's begin with the first case. We'll just discuss 2 cases, different aspects. So this was a 45-year-old carpenter who came to us from Siliguri. That was in 2019. He complained of continuous abdominal pain, had some burning extremities and back burning and pain in the back. There was weight loss of around 7 kgs over the past 6 months, and he was diabetic with poor glycemic control. And he was told that he might get cancer, so he had to undergo immediate surgery. And with the fear, he reached AIG with a CT scan like this. So if you see, there is a big chunk of stone in the dilated pancreatic duct in the head region. And of course, there is atrophy of the pancreas. If we go a little bit detail into the history, in 2013, actually, his disease started. The first episode of moderately severe acute pancreatitis. That time, there was no chronic pancreatitis. There was lots of necrosis. And then after that, he started having some recurrent acute pancreatitis from 2014 to 2016, and episodic abdominal pain in between those acute episodes, and there was some gradual weight loss. And from 2017 to 18, in between that duration, he was diagnosed to have diabetes, rightly started on metformin. There was persistent abdominal pain now. If you see, the pain pattern has changed. He has some persistence in the pain, and then he was treated as usual or as expected by pancreatic enzyme, and was also advised to take fat and oil-free diet. So he was not taking any fat and oil. He was just taking boiled food, as the people usually do. So this kind of situation, the patient would first usually present to a physician. So may I ask Madam Arunima ma'am, how do you approach this patient at this point, the preliminary evaluation with that set of history?
Thank you, Rupjyoti. First of all, you have elaborated the natural history of pancreas very nicely so that the PG students or whoever are seeing, they are getting a good gist of it. Now, if a patient like this comes with a history of pancreatitis, then like you have described several episodes of pancreatitis, and now it is more or less a constant pain is present, then basically the first will be a clinical evaluation. Like any other patient, we will examine the patient, and then we will go for a basic laboratory investigations. Like, for example, we'll go for a CBC and LFT and creatinine, and also certain other parameters, and particularly regarding blood sugar, the glycemic evaluation, HbA1c, and also for the C-peptide, to see whether how the insulin, endogenous insulin is present or not. And of course, with this, I would like to add ultrasonography.
Yeah, so I think yeah, that's what we also did when the patient presented to us. The goal here is to see two things. One is the functional reserve of the pancreas, and
Right.
and the other, and the nutritional aspects. So the functional reserve would be the beta cell function, HbA1c, that will tell us the beta cell reserve, and all the other tests directed to look at the nutritional parameters. And ultrasound would obviously give us a gist or gross idea of what is going on. Now, once this is done, the other thing that patient came is with pain. So how would you approach this patient, this acute pain episodes? I mean, how do you manage to treat these pain episodes in this patient?
First of all, I would like to say that managing pain in pancreatitis is very difficult. It's very difficult, and usually we start with like a low-fat diet. Though of course you're not in agreement with that, but we give a low-fat diet, and then we stop alcohol cessation and smoking cessation. And usually for the pain, we'll start with simple analgesics like paracetamol or ibuprofen. And if that doesn't work, and mostly it doesn't work, we have to go for the opioids, mostly tramadol. So that is for the painkiller. And there are other things also, like, for example, those medicines which alter the pain perception. For example, gabapentin or pregabalin, and at many times these patients, which is very true, the patients who come to us with chronic pancreatitis are depressed, very depressed because of they can't eat anything, they are in constant pain. So antidepressants are also given along with this. So this is briefly what how we approach the pain
Yes.
management initial.
Yeah. So I think, yeah, you have rightly said. Basically, if we look at the guidelines, every guidelines, they follow the WHO ladder. But as you rightly said, the non-steroidal anti-analgesics usually do not work. And
Right.
what we should start, or is usually start in routine clinical practice, is a low potency opiate like
Opiates.
tramadol hydrochloride, or the new drug called tapentadol. There is a little tendency in few centers, and this was very common in the West, to use high potency narcotics like codeine, morphine, buprenorphine. Now the West have burnt their fingers. They have known that they are actually giving the patient something called narcotic bowel syndrome. And this morphine and high potency analogs actually has a dependence potential, and they cause mast cell degranulation, which actually contributes to the pathophysiology, inflammation. So eventually, even we are reducing the pain in the short term, we might increase the inflammation in the long run if we use the high potency morphine derivative. So these high potency derived narcotics should be avoided: buprenorphine, morphine, albuphine, fentanyl.
Right.
So this is very important for the young PG students, and the young physicians in the audience should understand this, not to get into the knee-jerk reaction of, because these medications will do wonders. Immediately it will cause significant pain relief, but we might be harming the patient in the long run. So, and if given also, it should be given in a hospital setting with tight monitoring. But now let's come to Dr. Shiran. So now the pain has been kind of settled. We had done the investigation. Now we plan the treatment. But before that, so would you like to know some more, have some more information so that we can tailor make your treatment or customize your treatment? Dr. Shiran.
Yeah, thank you, sir. I think too, I think you're given a very good history and also the profile, the temporal profile of the patient with a long-standing disease, and also with some very points like there's a significant weight loss with recent uncontrolled diabetes. So I think there was an ultrasound done, which I think didn't pick up much. But once the acute episode is over with all the workup, initial preliminary workup, what we do, and also we need to have after a basic ultrasound scan in case to further evaluate, we would like to do a better imaging. A cross-sectional imaging will be fine. One is because of his long standing, and one of some of the alarming signs are there with him, despite an uncontrolled diabetes can be a causative agent for his recent change in this weight. But however, we would also like to think something, a sinister thing is going on in his thing. So we would like to get a better cross-sectional imaging based on the availability. Either I would like to do an MRI, MRCP, or at least a contrast, pancreatic protocols CT scan.
Yeah. So that is how I look at it. The four things that we need to see before starting any intervention: the parenchymal volume, because we'll be, so usually how do we treat analgesics, long-term pain medications, and pancreatic enzymes, and then interventions, be it endotherapy, be it surgery. So I think it would be very important to have an assessment of the parenchymal volume of the pancreas, and then the localization of the calculi. If we want to do an intervention, that could help us to select, should it be primarily endotherapy or primarily surgery. Again, you had rightly said to look at the ductal strictures, the ductal morphology, and more ominously, if there is any local complication or mass lesion. And particularly in this patient who had rapid weight loss and uncontrolled diabetes, so it would be important to look for a mass lesion. So if a patient like this has history of rapid weight loss, poor control of blood glucose, increasing intensity and change in nature of pain, these are red herring signs that these patients could be having an underlying malignancy. And here a pancreas protocol CT early on in the investigation becomes mandatory. So that we have burnt our fingers, and Dr. Adarsh Choudhary and Dr. Sanjay would agree with me. Many a times we miss this tumor early on, and then when they come back with a telltale sign, we already lose the window of opportunity for a curative treatment. So that index of suspicion should be very high in this kind of patients.
True,
now,
sir, I think rightly.
Yeah. So Dr. Choudhary or Dr. Banerjee would like to add something on that, on the imaging issues?
No, I'm okay with it. What you said makes a lot of sense. I'm thinking it.
Sure.
So can I ask a question? So, sir, in
Yeah.
case now I think most of the centers are actually well with a lot of cross-sectional images, both having a CT scan, and unlike earlier days where we had only one option or we need to send to the other center. But most of the centers do have both MRI as well as CT scan. So patient with an acute pain and acute exacerbation of a chronic pancreatitis after your initial evaluation, and once he's pain-free, which modality of cross-sectional imaging would you prefer in practice?
So I would prefer, basically what I'd want to know in this situation is, again, the ductal morphology, the parenchymal volume, and any other mass lesion. So my first choice in this situation would be a triphasic CT.
Okay.
Because the ductal stricture, suppose there is a duct in the stone in the head, anyway, he would need some intervention. So at that point, I may not be interested to know only about the stricture, in which case I would have done a MRCP. But CT will also give a good quality CT, some idea of a stricture. So my first choice would be
CT scan. Fine.
Yeah.
Can I make a point here?
Yes, sir, please.
What Dr. Rupjyoti said made a lot of sense. It depends on what the symptoms and what we are looking for.
Yeah.
If we are suspecting malignancy or something else, I will also do a contrast enhanced CT. If patient has predominantly pain or something, then I might not go to do an MRCP to find out
Yes.
the pancreatic duct. Am I right, Roop?
Yes,
That's what
exactly. Exactly.
Thank you so
And
much.
usually the patient that we see here would have a dilated duct with lots of stones.
Lots of stones. That's right.
Yeah. So,
That's
yeah.
right.
Yeah. So
During
now,
acute presentation,
Yeah.
the CT perhaps has an edge over MRI because the
exactly.
assessment of severity, assessment of
Oh,
local
yes.
complications,
Yeah.
Oh, yes.
You'll,
Oh, yes.
you'll
Oh.
also get the peripancreatic morphology.
inflammation.
Somehow MRCP is not a good investigation to assess the head mass.
Exactly.
It's very difficult.
Yeah.
Yes.
Yeah. So now we have a patient with idiopathic painful chronic pancreatitis. And again, it's very important to distinguish painful and painless, because if the patient is painless, we would probably not touch anything except for medical therapy. So that definition is important: painful with exocrine and endocrine insufficiency. And today, the primary point of discussion is pain. So Dr. Banerjee, how would you begin treatment in this patient?
So I think the symptomatic therapy, as Madam told, will start with NSAIDs or maybe low potency opioids. And after that, and a control of diabetes, obviously another part of
Yeah.
treatment. But after that, we have to treat the disease itself. So we
Right.
need some disease modifying therapy in its
Yes.
true sense. And for that, we must understand the pathogenesis and how the disease evolves, because chronic pancreatitis is characterized by pancreatic fibrosis that evolves over several years. Patient may or may not have clinically apparent pain. It could be a symptomatic disease progressing to the stage of fibrosis or superimposed with multiple episodes of acute pancreatitis. At the same time, what are the pathologic contributors to this disease process? Because if we can target that pathologic steps or pathologic contributors, so it is an inflammatory process. So there are multiple inflammatory contributors. This inflammation or the entry of inflammatory cells will cause oxidative stress. So we can modulate that, we can give antioxidant. And particularly in an advanced stage, there is also a neural sensitivity and neural component to this disease process. So we can also target that facet of pathobiology. At the same time, we must also understand what is the predominant morphologic presentation. Is this pain due to stricture? Is this pain due to stone? Is this pain due to an intraductal stone or a parenchymal stone? Is this pain is due to an superimposed extra process like pancreatic malignancy, or maybe an extra pancreatic complication like gastric outlet or biliary obstruction? So understanding both these pathologic contributors in each step, as well as the morphologic correlate of pain, is important to chalk out a therapy strategy to initiate therapy. Now, regarding inflammatory pathway, we don't have much of anti-inflammatory agent. You can call some of the analgesics are anti-inflammatory, but leave it. We don't have much of anti-inflammatory agent in therapy of chronic pancreatitis. People have tried, even recently there is a paper with Camposet, which is trypsin inhibitor, but they are preferably not useful. They are usually not useful in chronic pancreatitis. We have some separate experience in acute or maybe in posterior severe pancreatitis. Apart from anti-inflammatory, where the response or where the results are very disappointing, the second pathway which we can target in therapy is antioxidant, means giving antioxidant to
Right.
control the oxidative stress. And third part is controlling the neural sensitivity or neural inflammation. And regarding antioxidant, I think there is a scope. There are many studies starting as early as in 1992, 90s, earlier some studies of small open label studies, and subsequently we have good Indian data to suggest that antioxidants given at least for 6 months, in addition to the pain relieving medication, antioxidant given at least for the 6 months, particularly in the initial stage, can to some extent relieve the pain in a meaningful way.
Yeah, I think Dr. Banerjee, it was a very nice to classify the events and then talk about the approach. So yeah, as you rightly said, so what I call these are the mechanistic events, because there are mechanisms we don't see. It happens at the cellular level. And the other set which starts late are the morphological events. So the stone, ductal stricture, biliary stricture, lesions, all these are morphological events. And treatment usually is began with the mechanistic events, and the targets for this, as you rightly said, antioxidant, lots of studies. I won't go into the detail, but if we look at the largest study from India, from AIMS in 2019, there was some benefit. But what we should understand is it's not a like blanket kind of thing that every patient will be benefited. The patient in Indians, have more benefit because these are young patients. Most of them are non-alcoholic, and most importantly, they are not on non-narcotic analgesics. The Western studies which do not show demonstrated benefit were actually having elderly patients, and they were taking high dose of narcotics. So non-narcotic and non-alcoholic parameters has to be there to get a benefit from the antioxidant. And which antioxidant? Again, it should be something that contains high dose of methionine. It's not just the routine antioxidant that is available in the market. These are specifically designed for pancreatic diseases. And again, there are mechanistic hypothesis, which I won't go into the details, something called transsulfuration pathway, which gets disrupted, but methionine would restore it and then helps in reduction of inflammation. So that was the mechanistic event. Now, what about the morphologic event? So we had this patient who had pain. Now we talked about the medical part of the initial medical part of the treatment, but he had pain and an obvious ductal, obstructive ductal stone. Again, I'm using the and stressing on the word obstructive. All ductal stone will not cause so-called ductal hypertension, and we still don't know if ductal hypertension really exists or not. It's more of speculation, but in view of improvement of pain after removing the ductal obstruction or ductal stone, that concept has come across. So now we have this patient who have obstructed stone in the pancreatic duct, which is dilated, and it is imperative that we clear the duct with the hope that pain may come down. Now we have several modalities. Most commonly available in this country is ERCP, ESWL, and surgery. So now I'd like to call upon, usually in this kind of discussion, the endoscopist comes first, whether to use endotherapy or what. But today, let us go the other way around. And Adarsh, sir, what would you prefer? Your first choice in this particular patient?
Rupa, I will like to have possibly an MRCP in this patient.
Sure.
Because I need to find out whether the surgery will benefit this patient or not.
Yes.
Sometimes we make the mistake, we see a dilated duct only, and if there is no pancreatic substance, then surgery is not going to benefit this patient.
Exactly.
So we should get a good pancreatogram, evaluate, because though I'm a surgeon, I also know that surgery also doesn't give good long-term relief in many patients. So we should carefully select patients. We should not have a knee-jerk reaction. And I will think I'll get an MRCP in this patient and evaluate whether he's a surgical candidate or not.
Yes. And I think this is a very important message for that evaluation of the ductal system and the pancreatic parenchyma. We usually don't give importance to the parenchyma. We just look at the stone or the size of the duct. Oxidative stress is generated in the pancreatic parenchyma, and it is believed that the ductal obstruction causes oxidative stress. So if there is no parenchyma, there will be no oxidative stress. So if the pain comes in that patient, it has to be something extra pancreatic, maybe neural. So I think this is a great point that you have.
And Roop, many of these as surgeons, we forget to believe, we believe that by removing all the stones, we can relieve pain.
Yes.
That's not true.
Which I think is a myth. Yeah.
And calcification is a sign of chronic pancreatitis, is not a cause of pain.
Exactly. Yeah.
Thank you.
So, okay. So let's just quickly look at some of the surgical results. So this was a famous landmark trial published several years back in NEJM, surgery versus endoscopy. And here, at 2 years follow-up, surgery was found to be better in reducing the primary outcome, which was the Isbicki pain score. But when they followed these patients for 5 years, and now they have data for even more 10 years. So the primary outcome significance was gone. It was no longer significant compared to endotherapy. As Adarsh Choudhary was rightly saying, that surgery may not necessarily be beneficial. And this was a more recent, famously quoted trial called the ESCAPE trial, again from the Dutch group. And here again, there was a comparison between surgery and endotherapy. And if you see the red lines, endotherapy first approach had a higher pain at the end of 18 months compared to surgery first approach. But if we look carefully at this picture, the picture on the right, they have actually published as a supplementary material, not in the main manuscript. And here, if you see, and they have acknowledged this, that patient who had early surgery, blue lines, and patients in the endoscopy arm who actually underwent ductal clearance, there was no difference. So which means that ductal clearance and endotherapy, surgical ductal clearance and endotherapy first do not differ in pain relief in the long run. The same group had actually done this follow-up till 8 years, just published on 20th of November, I think, published online in JAMA. Here they had said that early surgery, but not endotherapy first approach, causes pain relief. But the caveat is even they had acknowledged the follow-up was non-standardized, like it was from less than 5 years to more than 10 years. Analysis was retrospective and done at only one single point. So lots of recall bias. And the interventions used during follow-up were non-standardized. And there was also no report of the effect size. So as clinicians, we would be more interested to look at the effect size rather than the p-value. P-value may be very good, but effect size, which is in the form of odds ratio relative risk, we have not recorded that. And 30% of the patients were excluded from the final analysis. So that makes it grossly underpowered. So that's brings the results of this study into question. And again, I think the benefit of one over the other becomes questionable. So it's not yet prime time to recommend surgery as the first choice. And we had written a letter to the editor, and they kindly accepted to publish that. It will come out in print soon. So now, what about endotherapy? And this question is for both of you are great endoscopists, Dr. Sanjay and Shiran. So what would be your take on endoscopic approach first in this patient?
I agree with this. I think ideal selection of patient is very crucial. Like Adarsh sir said, it's not always, when you see a large chunk of calcifications, or when you see one of the imaging without much evaluating, you should not jump for a conclusion. I think ideal selection is very important, but I always prefer, like, endoscopy is a less invasive than a surgery, because after surgery your options are very limited. So if your candidate is a very right candidate, like you have calcification with the stricture and a good parenchyma intact, and the pain is mainly because of the ductal hypertension, just relieving some of the ductal pressure will be benefiting your patient, and these are one of the best cases for the endotherapy. And also there's a single stone or the head stricture, no multiple strictures on them. Like I agree with sir that once you're planning for a definitive therapy or an advanced therapy, we should have a roadmap with an MRCP along with an CT scan or an MRI MRCP, so that which gives a very much clue that a patient has a only single dominant stricture in the head region, or calculus which in the head region, which many times we see in our practice. So then these are very one of the good cases where endotherapy will be useful, and I think few of the studies have shown very beneficial. And I think I would also like to add that ESWL, which is coming in the last few years practice, and the European Society says that one of the first line of therapy they want to use as ESWL, either isolated ESWL or ERCP. Along with ERCP, after pulverizing the stone and ductal clearance, is shown far more better results than just doing just placing a pancreatic stenting. I think that's a little bit of the game. Some of the studies which we got have shown a lot of reference isolated versus clearing the ESWL along with placing a stent has much better results than only placing in plastic stent.
Yeah.
I also echo his opinion. Proper case selection is important. There is no point subjecting patients with multiple stricture, numerous stones, chain of plaque appearance to endoscopy, because in any case, complete ductal clearance will not be possible. But for any given patient who is a suitable case for such endotherapy, I think endotherapy can give significant pain relief, at least for the initial 1 to 2 years. Now, one question regarding endotherapy is, will it be only ESWL or ESWL followed by endotherapy? There is a lot of debate, but all the debate arose because of a beautiful paper from Switzerland in Scandinavian Journal of Gastroenterology, where a very elite group has demonstrated that ESWL alone is sufficient. There is no need to go for endotherapy. But I don't think in AIG also, they routinely perform endotherapy after ESWL, and ESWL followed by endotherapy should be the norm.
Yeah. So the reason for using endotherapy after ESWL, again, it depends on the stone biology. The stone that we see are large chunk of stones, speculated large stones. So all the time, even if we fragment, it may not be cleared properly. So a sphincterotomy and the ductal clearance becomes important so that they do not get recurrence of pain. And it's not necessary that stent has to stay for long. Even at 3 months, we tend to remove, or maybe 6 months. But again, let's look at some of the endoscopy or ESWL results. This is a series, several studies collated in this table. And if we see here, if you see the pain relief is great, 85%, more than 80%. And all these patients had a follow-up of, say, around 14 months or 6 to 12 months. But when these patients were followed for longer, for example, 5 years, 7 years, there was a significant reduction in the pain relief. So what does this mean? Initially, as Dr. Banerjee said, for the first 1 or 2 year, they may get good relief. But as the duration of follow-up increases, the durability of the response comes down, right? So there must be something else going on, why this pain is not coming down or why the pain relapses. Now, all these studies that I showed in the previous chart were observational studies without a control arm. So we do not know how much is the placebo response and how much is a true response. And to answer that question, actually, we had published this paper just last year where we compared true ESWL with sham. Sham means like we subjected the patient to listen to the sound of the ESWL machine. We just made some little touch on the abdomen and just give a light pinprick to mimic epidural anesthesia. And what we see here, if you see here, so this green line diagram shows the improvement in ESWL ERP arm. And what happens to the sham arm? Even in the sham arm, there was a significant reduction over the weeks. There was some significant difference at 3 months, which was the primary endpoint. And so here it actually tells us that even in the sham arm, there could be some response. And these patients were actually also getting analgesics on demand. So it would again tell us that ESWL, even though it produces some significant benefit, it may not be durable or it may not be a great difference compared to the sham. So the beauty here is the patients requiring analgesics were much less in the ESWL arm. So this could be a driving point from this study. Rather than saying that ESWL or any kind of endotherapy shows great response, the more important point would be the analgesic or opiate requirement is significantly less in the patients who undergoes some kind of an endotherapy or probably surgery. So this is the driving point. So now, Adarsh sir, in which of the patients would you consider surgery as the first line intervention? No question of endotherapy, stenting, ESWL.
There are two situations, Rupjyoti, which come to my mind. Of course, one is a patient who has an emergency, that is separate, somebody who bleeds something.
Yeah.
But I think if you have a patient who's got a head mass,
yes,
and has pain,
Right.
I think in those patients, endotherapy doesn't work. You
Yes.
need some sort of a head coring or something. And the second is a patient in whom you cannot reliably exclude malignancy. They are the two conditions in which I think surgery should be considered as the first option.
And suppose a patient has a duct full of stone, I mean, or multiple strictures. So
Yeah,
would you-
then also I think that we should consider that a patient who's got a large number of strictures, stones, which
Yeah.
cannot be managed endoscopically, and I think surgery should be considered as first
I
option.
think this is the important driving point because there is some tendency just to try a stent first. So
No,
yeah,
that's
exactly.
right.
So that has to be very clear.
That you
That
cannot reach, and
yes,
especially also you'll also reach some patients, a small minority of patients who interestingly have a disease localized to the distal part of the
right,
pancreas.
right,
They are the ones in whom surgery can be very effective and
exactly.
endotherapy doesn't work.
Yeah.
Though we all know that it's a subgroup, but there are patients you would have seen.
Yeah, and we see a lot of them actually.
Yeah.
Only
So then surgery
from,
is because
yeah,
it's simple, it's effective,
yeah, just
and
remove
the stents don't reach. In them
yeah,
also we'll
and
surgery.
we end up causing more complication
More
by
complicated.
meeting
Yeah.
the wires and all. Yeah,
Right.
exactly.
That's
Yeah. So now what we came to know or what we realized from discussion till now, whatever you do, endotherapy, surgery, total pancreatitis, pain tends to be relapsing. So the durability of the currently existing modality is questionable. So usually we talk about which is better. Again, we had discussed this. It's not about surgery or endotherapy is better than the other. It's the complementarity, the right indication, disease morphology, duration of disease, and availability and expertise. That is also important. And another
Right.
important thing we never discuss is patient's choice. What does the patient want? we often fail to put the cards on the table and tell the patient, these are the choices, and you'd likely to benefit from this or this. So I think this is a very important thing that one should consider in their practice. So it's very important that the choices have to be individualized as per all these modalities or all these parameters. So this is how we optimize the plumbing and the wiring. So basically, we need to, again, it's kind of a repetition. It's a balancing act, basically, to see the indication, the right modality, to see how much non-efficiency or non-efficacy, then safety, durability. Now, I think, so that was about the case number 1. So this is case 2. Okay. So this is another middle-aged man who had continuous documented chronic pancreatitis, burning abdominal pain, burning extremities, significant weight loss. Again, a common practice advised to have take fat-free, oil-free diet, and again, diabetes with poor glycemic control. This is the imaging. Grossly atrophic pancreas, dilated duct, and the whole duct is filled with hard stones. And so this patient actually underwent LPJ, which was rightly done, at least looking at the ductal morphology, but we do not know how much efficacy it would have had. And then there was some relief of pain for a few months, and then he came back to AIG. This was done somewhere again in West Bengal. And then he came back with a relapse of pain. Then there was pain over the surgical scar, and he was treated with all kind of opiates and, of course, PERT and dietary modifications. So, Dr. Shiran, why do you think that there has been a relapse in pain in this patient? And how do you approach that?
Yes, sir. I think one is, I think we need to review his case, because you're given a couple of history, like he has significant weight loss and uncontrolled diabetes. And whether the case selection was appropriate or not, we can always find out. And also, if it was rightly done, whether anything else was missed. So I would like to have a point, like, something really, because if it was rightly done, like you rightly said, if it is really done right with the expert hand, so we need to relook into any other causes of pain, and also maybe whether any has an underlying inflammatory, he had an inflammatory mass or a structure, which has, which was not picked up on the first initial evaluation or imaging. I think that's one reason. The other reason might be a failure of the procedure, where significant ductal hypertension would have not been relieved. And third itself can be, once again, uncontrolled diabetes can also be one of the cause for, further episode of pain, and that also should be tackled.
Can I make a comment? Sorry,
Yes, sure.
Dr. Arunima, you first. Dr. Arunima, you spoke first.
Yeah. Actually, what I wanted to say that uncontrolled diabetes per se will not cause pain. Actually, it's the other way around. In uncontrolled diabetes for a long period of time, neuropathy occurs. So I don't think that this will be related to the pain of chronic pancreatitis.
As a surgeon,
it may be other causes, something, because the wound of the person is also painful. Maybe psychological problems may be there. Whatever. Please express your view also in this.
as a surgeon, I think the first thing we ask these patients is that if they continue to smoke or drink, that's the first thing we ask.
Yes.
And
That is important.
The first thing we think is, are you smoking and drinking? Because maybe this is an improperly patient surgery was not indicated. And second thing, we always get worried in such a patient is there underlying malignancy? There are two things we always bother about these patients. Of course, selection on what you, Dr. Shiran, said is right, but as a surgeon, we think of these two things. But these patients are the most difficult to manage in any context.
Absolutely agree. So exactly, yeah, whatever you said, I mean, to look for any new morphological changes, new stricture, new stone, and most ominously, yes, of course, head mass with a potential malignancy. So now, while we are talking about a head mass, so this patient did not have a head mass, but since it has come into context, again, I am coming to Adarsh sir. So how do you approach the patient with CP with a head mass? I mean, it could be malignancy, it could be inflammatory.
You know it better than me. It's one of the most difficult, challenging situations. So we do everything possible. We'll do a CT, we'll do a PET, And to my mind today, the most relevant investigation is to do an EUS guided FNA.
Yeah.
I mean, apart from everything else, that's the only thing. We will rarely ever do an upfront resection. We'll nearly always exhaust all the investigations possible to reach a diagnosis. So, but I think,
yeah, go ahead.
and I think EUS FNA is a necessary tool. But yes, if we cannot do, sometimes we resect these patients, but without investigations, we never do an upfront resection.
Okay. And regarding US FNA, you would do FNA for all patients, I mean, at all locations, or you'd be restricted to either head or because if there is a malignancy, again, that scare of sibling deposits is always.
We only do in the head, because if you practically see, even if you resect these patients, I don't want to sound nihilistic, the long-term outcome in these patients is not very good.
Yes.
We will only do a biopsy from the head. I don't know if I'm right or wrong, but we do only from the head.
Yeah, I think that's what we follow at AIG even, but it's important because again, if you have to remove the head, if there's sibling also, the duodenum will come out. But in the tail or body, you may be depositing it all through the track, and so that's probably more of a theoretical risk, but still there is a risk. So head FNA is what we even we prefer at AIG. Okay, so now.
So may I add one thing?
Yes.
Normally, the sensitivity of CT to detect pancreatic mass and to characterize the mass is at approximately 85%. But in presence of chronic pancreatitis, this sensitivity decreases to 75%.
Yeah.
75%.
Yeah.
So, and US particularly, because we have facilities for US guided elastography as well, where the tissue stiffness gives us more information about the possible malignancy or inflammatory mass. And along with this, US elastography and US guided FNA gives a sensitivity of close to 90 to 100%.
And
so
elastography would actually make you take more targeted biopsies.
And for elastography, we can be more targeted to for the precise location. So US and FNA and elastography has a very, very high sensitivity, close to 90-99%.
Agreed.
Much higher than CT scan.
Sanjay, we don't do a CT to diagnose a malignancy in such patients. We do a CT to see the anatomical configuration, that if we have to operate, what are the relation to vessels and all. Okay. So CT, you cannot diagnose CT, because I agree with you. So you have to use some modality of EUS and some techniques to reach a diagnosis. I agree with you on that.
And again,
can I have a question?
Sure.
Sir, Rup sir, and just to Rup sir and Adarsh sir. Sir, with usually we see similar scenarios with a lot of calcification with the bulky head. We very difficult to differentiate between the inflammatory mass, and we burnt the fingers. Many times we say, and he's not fit for surgery, and sometimes we follow him and he comes with a metastatic disease. So I just want to ask, somewhere I think not every center will have an EUS, so just for the juniors, so any role of a serological, any role of a biomarker here, or whether we can keep track of that, or any new generation MRI, because now we have new MRIs which have very soft tissues, and they can differentiate soft tissue, and also they can have vascular anatomy evaluation with new generation sequencing MRIs. Other than EUS, I just wanted an opinion, sir.
Shiran, the question is interesting. If somebody has a new generation MRI, they'll have an EUS also. But you're
as endoscopist, I would love to have that, sir. But just
I'm not defying you. But what I'm saying is the data for diffusion weighted image, all these things is very soft. But I agree with you. We all make mistakes. We've done head coring for patients, and the biopsy comes as malignancy. About 4 to 5% of our resections in Whipple's turn out to be benign. So there are some patients, no matter what you do, you cannot really make sense. Yeah.
And regarding biomarker, I think only the serum biomarker CA19, which I never do to look for a cancer.
Absolutely.
It should not be done. It's very commonly done in routine practice, but this message through this webinar should go very clear. CA19 should not be used as a marker of malignancy or to diagnose malignancy. So again.
And also, Rupjyoti, I want to say that in this patient which we are discussing, the other causes of the medical causes of CP has to be considered also, because since the patient is having a relapse of pain.
Yes.
So other causes, it may be something, say hypercalcemia, it may be hypertriglyceridemia. So all these things have to be ruled out also. So why has the thing, and genetic causes, autoimmune causes. So these also have to be ruled out.
And other non-pancreatic causes we often forget because
Non-pancreatic.
we are
Yes,
very
very
focused.
often
It
forget.
could be just some gastric ulcer, duodenal ulcer. It could be some biliary colic. So those things
Yes.
also should. I mean, all pain in chronic pancreatitis may not necessarily be pancreatic. So that is something we should remember. So for
Right.
this question, and all of you can chip in. How do you differentiate? Because we wait for the radiologist report, but even in the bedside, we see the CT scan films, right? So how do we differentiate between an inflammatory head mass or a primary malignancy on the background of chronic pancreatitis? So I have
Rupjyoti,
put some, yeah.
my most important sign is the duct penetration.
Yeah.
All other signs I see, but if I see, for me, duct penetration is very important. If a duct goes through the mass, it's unlikely to be malignancy.
Malignant,
Right.
right.
And other things like peripheral pushing of calcification, duct ratio, vessel abnormality are secondary.
Because
But I
of-
think in our experience, the duct penetration is the single most important sign. I'm not
Yeah.
saying it's most accurate, but of
Yeah.
all the available signs, that's the most
reliable.
useful.
Agreed. So this is a very nice example. So this is a mass lesion here, and the duct is going through the mass lesion. So it is very nicely visible on MRI and MRCP. And I agree with you, sir, that would give more weightage to it being a predominantly inflammatory mass. And again, other soft.
And sorry for a minute. And in the previous scan you just showed, there is the collateral ductal dilatation also means it's most likely to be benign.
Yes,
Because if the collateral ducts are dilated, it's unlikely to be malignancy. You agree?
Yeah. And then the duct cutoff can give you an inclination. Okay, there is a sudden cutoff of a dilated duct. So the head mass, but in CP we usually do not see such beautiful cutoffs, and so this is a primary malignancy, actually not a malignancy on CP. But as you rightly said, on the background of CP, that is the most reliable, the duct penetrating sign. And Dr. Banerjee, you have any further comments on this?
Certain this city, particularly radiological imaging differentiating features, but amongst them, I think the maximum sensitivity is for duct penetrating sign. This displaced calcification, duct parenchyma ratio, SMA versus SMB ratio. I think there are some other measurements, but having very low sensitivity. Duct penetration sign and duct cutoff signs are very sensitive.
I agree. Yeah. Okay.
But this is radiological, we need tissue to diagnose malignancy. So that
Yes,
is
yes,
US is always
beyond
US is
Yes,
always
yes,
preferred.
yes, yes. Absolutely.
that's beyond doubt. Now, this patient actually had burnt all the medical therapy, antioxidants, narcotics, and all. Surgery gives some benefit, short duration pain relapse. So there must be something else going on beyond what we are seeing, like eyeball view. So at this point, would you like to phenotype the pain, understand the pain better before proceeding to other? Because now there are other medical therapy which we can chip in, but to select the right kind of modality, would like to phenotype the pain. Dr. Banerjee.
Understanding the basic clinical medicine is very important here.
Yeah.
Means why do patients of chronic pancreatitis have pain? We have some of the seminal work by, you all know, this Amman's group, which has initially related that there are two types of pain. One is acute episodes of pain, another is persistent pain. But now we know that this is since 1986, the literature. But now we know there are variations. It could be acute persistent pain with some fluctuations. It's persistent pain. There could be acute episodes with pain with pain in between, or acute episodes with no pain in between. Most important, even than that, is what is the exact quality, what are the qualities of the pain, what is the character of pain, what is the location of pain, is there any recent change in the character of pain, or whether this is spreading over newer areas, and is there the relation of pain with specific triggers. Likewise, suppose if a patient has a long-standing chronic pancreatitis, we have seen most of the patients complaining of significant severe back pain. Hardly they complain of any pain in the epigastrium unless they have an acute episode.
Yeah.
Similarly, patients who have a ductal obstruction, they sometimes complain of a colicky pain even, and that is related to meal. So, giving importance to these small clinical parameters, means small clinical informations regarding the pain pattern, pain character, and particularly when you are considering malignancy, any change in the character of pain, or when you are considering a neural hypersensitivity, involvement of newer areas and pain spreading over other areas, this is also important. As is also important, you are showing this anxiety and depression, which can perpetuate the pain and brings down the pain threshold.
Oh.
I think this is very important, and this brings the importance of good history taking. In spite of all the fancy investigation we have, dynamic MR, EUS elastography, history taking is still important, and I think a good history can direct you to choose the right patient for the right treatment for the right patient. And as Dr. Banerjee said, like this could indicate neuropathy. So this is just a schematic diagram, just for explanation. So normally, when only the pancreas is stimulated or pancreas is injured, there will be nociception. I won't go into the details, but only the area in the spinal cord that uh, supplies the pancreatic segment gets activated. But when there is neural sensitization, there is hypersensitivity to the whole spine. The segment above and below the pancreatic segments also get sensitized. So food in the stomach can cause pain. So that or any movement in the intestine can mimic pain. So this is where the history becomes important. Spreading of pain, more involvement of more dermatomes, that would indicate more spinal hypersensitivity. So that is what Dr. Banerjee meant by taking a history of involvement of new areas, change in character, trigger. And this is data from the pancreas clinic at our institute, like nearly 300 patients. One very important thing was almost 25% of these patients had spontaneous pain. There were apparently no trigger, but they complained of pain. But if we dig into the history, these are usually young people, young students, maybe. They have some assignment in school or college that will trigger the pain. They don't realize that that assignment or that stress is causing the pain. Or some adverse event in the family, someone in the family died, someone in the neighborhood had an accident. So those kind of things can also indirectly initiate pain, which means that something is going on in the brain that is reducing the pain threshold, or the perception is changing. So this is very important to understand, because in this kind of patient, no kind of endotherapy, no antioxidant will help. We have to tackle the neural pathways. So, and again, there is an important parameter called COMPAT SF that was published a few years back. That because again, pain is not as simple as we usually think. It has several dimensions: severity, fluctuation, provocation, spreading pain, and qualitative pain. And this COMPAT SF questionnaire actually captured this very well. And we have now translated into Telugu, Hindi, and Bengali. So it will be available soon. It just got accepted in the Indian Journal of Gastroenterology, and people can use this for our patient. We have validated in the Indian context. So this is a new tool that is soon going to be available for pain phenotyping. The other thing is Dr. Banerjee already told about sensitization. This I won't go into details because we have to do some specific tests called quantitative sensory testing and looking at the variability between EEG, ECG. These are special techniques not available. These are research tools that we have started, and now AIMS New Delhi is also doing under research protocols. So where we try to see the temporal summation and the spinal hypersensitivity. And then this is again, we have started a research protocol in collaboration with the IIT Hyderabad to develop some indigenous way to look at the facial expression, infrared camera to look at the facial blood flow in response to pain, and of course ECG, EEG. So this I won't go into the details. But then this quantitative sensory testing is a research tool, and it has good sensitivity, but it's not available for all centers. So this is a study that we did. If we can find some clinical surrogates that would identify sensitization even without doing pancreatic quantitative sensory testing. And these are the results. We are about to publish this paper. Involvement of new areas in those patients who had involvement of new areas, long-standing diabetes, significant depression. So 2 to 4-fold higher risk of having widespread sensitization. So if you're a patient who has come back after all the other therapeutic modalities, this history is very important. Just 3 or 4 questions: involvement of new areas, change in character, long-standing diabetes. If these are there, they can you can confidently make a diagnosis of neuropathy, pancreatic neuropathy. So again, I'm reiterating, take a very good history of pain. It's not about just having pain or not having pain. It's the pain details of the pain, the characterization of pain that could help us in determining the right kind of treatment. So now, this patient, when we took that history, actually his pain character had changed. That food intake brings up a burning type of pain in the abdomen and back. And then there are spontaneous spells of low-grade pain that continues for a few days. And there was also a burning over the surgical scar. And again, the surgical scar is in the dermatome of the pancreatic region. So again, that could be involved in the neural hyper thing. So how do you treat, now we know that this patient has pancreatic neuropathy. So I come to Shiran, how do you treat this patient now?
Yeah, I think, sir, you beautifully shown all the picture, like what is the cause for pain, basically when it's neural hypersensitivity and involving multi-dermatomal involvement. So one is obviously the general measures are like you have to give all the cocktail of antioxidants. If he has a risk factor of die, if he's still smoking, that's very important. He has to cut down, or he has to quit smoking, good lifestyle. And non-pharmacotherapy measures has to be started. And like obviously many patients have stressors, which we have to focus on that and try to try to treat those stressors or a small amount of depression. The other thing is you have a lot of neuromodulators which are in. We ideally earlier we used to give TCS, tricyclic antidepressants. Also,
Right.
pregabalin, also study has been shown very good results with neuralgic type of pain, which is with minimal side effects. So we can try either a TCS or pregabalin neuromol. The neuromodulators can be done with an optimum dose, with continuous follow up and managing. Is if you have a pain score and if it responds well to the neuromodulators, I think that's the one way your analgesic requirement keeps coming down.
Yeah. So then this was that study from the Netherlands group. And then this was one of our studies where we combined neuromodulator with antioxidant. Again, there was some benefit. So again, I'll quickly go to thing. So yeah, so this is again a very popular modality, celiac plexus block. And we have seen patients coming to us with several celiac plexus block and again, pain coming back. So what is your opinion on this, Dr. Banerjee?
Celiac plexus block is usually given with triamcinolone and bupivacaine in a measured quantities. These are for temporarily blocking the celiac ganglia or celiac plexus. Uh, as a modality of therapy to control pain in chronic pancreatitis, actually, I am the person in Kolkata perhaps who have done maximum number of celiac plexus block US guided.
Okay.
But my personal experience is that this is a futile attempt. It gives minimal pain relief, though the literature says that 60% patients are pain-free at average 6 weeks. But most of my patients come back within 2 to 3 weeks with equal pain than that they had before. So celiac plexus block is not a good modality of therapy for controlling pain. It gives some relief of pain, maybe for the 2 to 3 weeks.
Yeah.
But again, most of the patients are having significant pain on follow-up.
That's the same experience that we also have had all these years. And I have not advised a single celiac block in the last 10 years. Few patients on
Somehow in this part of the Kolkata, nobody does it. So people usually refer cases to me. That's so unfortunate.
because cancer is a different story. I mean, they have
Yes,
a
yes. But celiac plexus neurolysis for pancreatic
Yeah.
cancer or other retroperitoneal
Yeah.
malignancy, which
Yes.
is done with absolute alcohol to
Alcohol.
permanently destroy the ganglia. This is a good
It's a
outcome.
good model.
So, Arup, can I make a comment?
Yes,
So just
sure. I
lighter
was about
side,
to ask you. Yeah.
lighter side. When we do surgery, we cannot find the ganglion where they are. I don't know how people can find it, because in that area it's not easy.
Yeah.
Sanjay is surprised. Sanjay is surprised.
No, sir, there's some ecogenic structure on the just celiac takeoff. We identify that area.
You think it's a ganglion, no? You think it's a ganglion.
Yes.
Of course,
You think. The problem with life is when you interpret your beliefs as facts. That's when problems start. I'm just joking on that.
And
But
standardized
I
by
agree with
myself.
you. I agree with you. It never works. It never works. It
Yeah.
never works.
And since you are in here, sir, I'd like to ask you, does celiac plexus block interfere with surgery? Suppose this patient have to undergo some surgery.
No, it doesn't. It doesn't.
It doesn't. So fibrosis, especially if alcohol is used.
We don't know. No, it doesn't.
Okay.
So,
I've seen
so
some
can
patients
one
developing
question to Sanjay,
hypotension, but
sir.
diarrhea I have not seen. Some
Yeah.
patients
I have
develop
seen
Sanjay,
diarrhea.
sir.
I have seen
Hypotension.
Sanjay,
diarrhea.
sir, you said,
Yeah.
Some
Sanjay, sir, you've done
patients-
a lot of celiac plexus block. What's your, what are the serious side effects you've encountered? We don't have much experience. We have done very few in our center, so like it doesn't work. So we stopped doing now. But you said you have large series of patients. What are the dreaded problems you have encountered, sir?
Few of my patients have diarrhea, but that usually subsides within 2 to 3 days. Perioperative hypotension is really concerned. Most of patients develop hypotension, and our anesthetists are usually keep a vigil on them. We need to
And
improve
Sanjay,
the
some
knowledge.
patients develop gastroparesis also,
Yes.
Is it
gastroparesis.
So
Gastroparesis.
gastroparesis, I have not
from the
experienced
celiac
most of the
plexus?
patients.
Okay.
Maybe that effect does not
Gotcha.
last that long to cause gastroparesis. I think diarrhea for 2 to 3 days is quite common, and perioperative hypotension,
So
periprocedural hypotension.
I had a patient like that was long back when I just joined AIG, a lady from Assam. I somehow decided to advise a celiac block because of pain, and it did not help her pain, but she got diarrhea for several months, almost a year, watery diarrhea. And hypotension is, yes, we do see lots of hypotension. So diarrhea is there, and so usually it is for a few days or maybe weeks, but in rare situation there could be longer duration diarrhea. So, and then again, medical modalities. Dr. Banerjee already talked about Camostat. There was a recent paper published in Gastro, multi-center, that did not show any benefit.
So any benefits.
This was another study that we recently completed, soon going to publish, using non-enteric coated pancreatic enzymes, because there was a hypothesis that non-enteric coated enzymes could reduce pain by inhibiting the feedback loop. But we could not demonstrate any benefit between the non-enteric port versus placebo. So this is also something that
So what was the dose you gave in this study?
we gave a high dose of protease.
High doses.
High dose of protease, 30,000 unit of protease. That is
Yes,
what
yes.
more than 25,000
Yes,
is
yes, yes. In
recommended.
spite of that, it did not show any
It did
benefit.
not work. It did not work. Yeah.
Okay.
So that is the one. So now, so it's already 5 past 9. Shall we continue? I mean, a few more slides, or shall we stop? Organizers and the panelists, if you want to continue, then we can do. Otherwise, we can stop.
We will
here.
wind up with this question.
Okay, sure. So yeah, so now Arunima ma'am, you had been discussing about depression, anxiety. So how do you like to evaluate the psychological aspects at this stage? Because obviously after so much of pain and so many years of disease, there is bound to be psychological issues.
Actually, after so much of brainstorming, this has come to a very basic question, like how to evaluate these patients for psychological problems. They are usually depressed, so there are different scores which we can use. One is a hospital anxiety and depression score, and then there is a pancreatic catastrophic pain score. So these things can be done, but again, these scores are very subjective. So, for example, if the HAT score, if it is more than 11, and in the PCS score, if it is more than 30, then of course these patients definitely have this deep psychological problems, which leads to very difficulty in coping with the disease. So in these cases, definitely we have to go for antidepressants and other modalities, as already been said, like the neural medicines which alter the interpretation of pain, like pregabalin or gabapentin, or the TCAs which were used initially. So these things are there, and antidepressants have to be given. And also we have to go for cognitive behavioral therapy. So with this, I think this is a more, but it is like even the pain management, many areas are gray. Even logical problems also, like what exactly has to be given is not very clearly defined.
And in fact, people have tried ketamine, people have tried yoga therapy, people have tried octreotide, several things have been tried. But problem is we don't have high quality data. Even with antioxidant, antidepressant, it's more of our perception based on which we treat these patients. There are no good quality data. And I think if some interested PG students are in the audience, they can initiate this kind of study, use of antidepressant, anti-anxiety. CBT, a recent paper has come out, but I think we need more data. What we do at AIG is called personalized counseling. We just explain them about their disease, and we see some benefit in the different pain scores and cognitive behavior. And then again, we are trying to develop some predicting model. This is just the initial part using an artificial intelligence to predict pain relapse. And again, if we see here, again, these things come in: change in pain character, predominant pain pattern, development of new areas. So these are very important factors which can predict pain relapse, and that can help us guide the therapy. So again, good history taking. So I ultimately, I think I'll just finish it off here. So it has to be a multidimensional evaluation. Think out of the duct. Pancreatitis treatment is not about the duct. It's about the parenchyma and beyond the parenchyma, including the cognitive areas of the brain. So that is very important. So I'll just skip this. I'll come to the last slide. This is the optimized therapy based on what we discussed all this last 1 hour. Chronic pancreatitis with recurrent abdominal pain. If the patient has idiopathic disease and a preserved parenchyma, that is very important. No parenchyma, antioxidant.
Right.
If it is preserved parenchyma, we can start off with methionine containing antioxidant. Again, I always put emphasis on the word methionine because that is what provides the thiol group to the transsulfuration pathway. But the problem is there is no only methionine and antioxidants. So it comes in a combination of 5. So we have to use it that way. Then a morphological evaluation is very important, as all the panelists has beautifully discussed. So if there is morphological change or no morphological change, pain phenotyping and psychological assessment is very important. We should not wait for the pain to come back. This kind of evaluation should be upfront, so that at the beginning of treatment, we know the morphological and psychological status, and that can be repeated multiple times during the natural history of the disease. If there is a morphological change, proximal stone, single stricture, the line of treatment is different, ESWL endotherapy. Panductal stone, multiple stricture, local complication surgery becomes the primary modality. And then if the patient has issues with pain phenotype, pain behavior, pain characterization, neuropathy, or they have depression, anxiety, go for counseling, antidepressant, anti-anxiety, still experimental, but it works in some patient at least. And the neuromodulatory if it is sensitization. The harrowing thing that comes is pain relapse. Again, if there is pain relapse after whatever we do, endotherapy, surgery, again, a morphological evaluation, especially if there is underlying malignancy, new stone, new stricture, or whatever morphological changes, and also pain phenotyping, psychological assessment. And in this group of patient, we are more likely to find positive finding in the pain phenotyping and psychological assessment. Usually they would have depression and other sensitization related issues. And if these are present, go for again counseling, anti-anxiety, neuromodulator. If morphological evaluation shows some abnormality, again we can go back with the local morphological treatment. And I think I'll stop here. And I'd suggest all the youngsters in the audience to go through this grand round that was just recently published in Gastroenterology. Again, it's a case-based discussion of different aspects, and you get both a Western and Eastern perspective of the treatment of this disease, because the disease that we see in India or Eastern part of the world is grossly different from what is seen in the West. And this grand rounds will give you a taste of both the Eastern and Western perspective. So with this, I think I'll stop here, and maybe, I don't know if there are any questions. And thank you to all the panelists for your wonderful discussion and suggestion, and the way we have brought up the topics and different points. Any last moment, one-liner comments from the 4 of you?
Well done, Rupjyoti. Fantastic. You were amazing. So much to learn from you. So much to learn. Thank you. Thank you.
Thank
Sir,
you.
there are some questions are there in question and answer section. I think many of them have gone through regarding the treatment. You can just take it from there.
Okay, quickly we'll go through the, how much. So I'll read out the question, so maybe the panelists can also chip in. How much chance is there? This is by an anonymous. They didn't put the name. Is there that a diabetic can be affected with pancreatitis and pancreatic cancer? Any of the panelists can pick this up. Shiran, Dr. Banerjee. A diabetic can be affected with pancreatitis and pancreatic cancer.
So the correlation of pancreatic cancer and diabetes is well established.
Yeah.
If you have an uncontrolled diabetes, or it's a precursor or a pre-malignant, we assume that there is a chance of having more chance of pancreatic cancer when he comes with a very uncontrolled diabetes who was well controlled in the past. And obviously on the acute pancreatitis, obviously you will have a fluctuation in the hyperglycemic control losses when you have an acute severe exacerbation because of change in your pharmacotherapy as well as food habits. So it's very important to have a optimum glycemic control along with the pain management, which is very, very important for the outcome.
Another
Yeah.
point I want to raise here that there are many drugs which cause pancreatitis. Many drugs which are commonly used, particularly for schizophrenia, the antipsychotic drugs, they cause both pancreatitis as well as CA pancreas. So that part also has to be seen in
And
the
the
pictures.
other point is diabetes with long-standing insulin therapy. So that can increase the risk because of the insulin-trophic growth promoting effect.
Yeah.
It has been shown metformin reduces the risk of cancer in general, not necessarily pancreas and insulin. So that is one. Okay, the next question is fasting going to help to improve pain? Maybe in the acute phase, but we cannot keep a patient fasting for months, right? So acute phase, yes, it will help. But then that's not a long-term solution. Glutathione is having any role in pain management in CP? Glutathione is an antioxidant, and there is it has been shown that there is loss of glutathione in patients with CP, but there are no evidence to prove or disprove that glutathione supplementation alone work or not. We don't know that. This is an interesting question. Is there any particular position while sleeping going to reduce the pain? Anyone?
That is, they can't lie down on the back. That's a problem in pancreatitis.
Yeah, so I think this works well when you are having acute pain, the acute exacerbations. But for the chronic pain that we are talking about today, I don't think I don't know, Dr. Banerjee, if you have any idea on that. I mean, any comment? Sleeping position, improving pain.
No, there are some positions because most of the patients, because of back pain, they prefer stoop posture or curled position to decrease the pain. But any specific position to improve the pain, I don't think there is any such position. Now, I just want to add one thing. There is recently a paper, I think, in gastroenterology or maybe American College of Gastroenterology, that amongst all the anti-diabetic drugs, GLP-1 receptor agonists in a patients of chronic pancreatitis prevents development of pancreatic cancer.
Yes.
They have compared with each and every drugs, including SGLT2 inhibitors, DPP4 inhibitors, insulin, metformin, and only the GLP-1 receptor agonists have been shown to have give this benefit. They prevent development of pancreatic cancer.
And also groove pancreatitis.
Yeah. So now the role of morphine in pain management in chronic pancreatitis, morphine will reduce pain, but it should be avoided because the adverse events would outweigh the pain in the long run. So
morphine increases the tone of sphincter of OT, so theoretically it might increase the pain. That is the reason. That is we all taught in pharmacology.
Yes.
That's right.
Any long injection of analgesic treatment gave reduced pain? I am not aware of any long injection of analgesic. I mean, so we should avoid analgesics as much as possible. That's the dictum. We should look at the other non-analgesic modalities. Whenever analgesic is required, use it for a short duration under monitoring, preferably low potency narcotics. This is for Adarsh Choudhary, sir. What percentage of chronic pancreatitis patient with severe pain requires surgery?
Well, it's difficult to give a figure to it. Very difficult to give a figure. It all depends on a center's belief. I think the figure will range from about 5 to 20%, varying from centers to centers.
Yeah. Okay, that's fair enough. Yeah. How can we differ the diabetic neuropathy and pancreatic neuropathy? Again, interesting question. Pancreatic quantitative sensory testing can differentiate because in diabetic neuropathy, we will not see much of the central sensitization or the temporal summation. PQST has different parameters. You can look at localized sensitization, where only a small part of the dermatome gets sensitized, mainly the T10, L1, L2. And in
diabetic neuropathy, you have a whole gamut of tests.
Yeah.
So there, even the ECG which you are doing, so the RR variability also goes for you guys.
Exactly. So it's difficult, but PQST can give some idea. And then again, we have to go by the history. Ulinastatin is not effective in pancreatic pain, especially chronic pancreatitis. Mebaverin, there are no data, but I sometimes use mebaverin in patients with, who appears to have neuropathic pain, because especially patient who has postprandial pain, and the pathway is followed by this situation NCP is same as the pathway that is followed in IBS, pain predominant IBS. So mebaverine sometimes help. I cannot give you randomized data. Again, that is a good thing for a trial. But in some patient, yes, I do think mebaverine helps. So yeah, I think we have covered all the questions. So I think, yeah, that's it. And thank you to all the panelists, to the organizers, and all the beautiful audience who have stayed back now. I think we have at this point 138, but I think there are much more, right, Pradipta?
Yes.
How
Yes,
much
sir. It's 200 plus at one go. I have seen. So
Yeah.
total, I have to check, sir. Tomorrow I'll let you know.
So I hand it over to the organizers, Pradipta, and
Thank you, Rupjyoti, for a
Thank you,
lovely
ma'am.
conducted
Excellent
this program.
presentation.
Thank you.
Excellent presentation.
So
Thank you,
you
sir.
all for
Beautifully.
joining us.
Thank you, the
Beautiful
other
presentation.
panelists also.
Thank you.
So
Thank you,
thank you
madam.
all for
Thank
joining
you.
us today, especially Dr. Rupjyoti sir and all other panelists. So thank you all for having the webinar on pain and chronic pancreatitis. We hope you found it informative and valuable for practice. Special thanks to again Dr. Rupjyoti Talukdar for expertly moderating and sharing insightful perspectives. We also appreciate the panelists and the other participations and thoughtful questions which truly interested. So this session was enriched by Enzelo. Thank you all. Thank you all the panelists also. Thank you very much, sir.
Thank you. Have a good night. Bye-bye.
Good night, sir.
Thank you. Thank you, everyone. Have a good night.
Thank
Bye.
you.
Good night, sir.
Good night.